This is Brendan at the Brookbush Institute, and in this video we're going over static release techniques for the Flexor Hallucis Longus and Flexor Digitorum Longus, also known as the FHL and the FDL, or the long toe flexors. If you're watching this video, I'm assuming you're watching it for educational purposes and that you're a licensed manual practitioner. That means the laws in your state allow you to perform manual release techniques, namely physical therapists, athletic trainers, chiropractors, and massage therapists. I'm going to have my friend Melissa come out. She's going to help me demonstrate this technique. Now, these muscles are deep, and the posterior lower leg here is kind of sensitive when it comes to these manual release techniques. Before I attempt FHL or FDL release, I want to be fairly certain that these muscles are involved. So Melissa, at this point, I'm going to have done assessment, and she's going to exhibit signs of lower extremity dysfunction before I start poking around at these deeper muscles. That could be anything from feet flat, feet turn out, knees bow in, knees bow out, or excessive forward lean on that overhead squat, a lack of dorsiflexion on goniometry, maybe her manual muscle testing for her tibialis anterior or tibialis posterior came back a little weak. Maybe that gastroc soleus muscle length test showed me some changes in extensibility in her plantar flexors. These would all be good reasons for me to dig a little deeper, start palpating, and see if I could find some increased tissue tonicity, or increased tissue density is what I'm actually going to feel with palpating the FHL and FDL. Now, to help you guys with the palpation part, because that's probably the most difficult part of this technique, I'm going to have Melissa scoot down just a little bit. I want to be able to control dorsiflexion here with my thigh. Alright, so then what I'm going to do is I kind of know where my trigger points are for these muscles. I know that my FDL, it's kind of like a spot right between the lateral and medial gastroc, but a little higher than the lower border. It's like up a little bit. And then I know my FHL, you guys have probably felt your Flexor Hallucis Longus trigger points or seen somebody try to roll at their Flexor Hallucis Longus trigger points. It's kind of a spot that seems to be inside the Achilles tendon. So if you've ever seen somebody foam roll really low, chances are that's not their gastroc or soleus. Their gastroc or soleus ends up, well, their gastroc up here and their soleus here. If they're just kind of rolling over what you thought was tendon, chances are it's the muscle belly of the Flexor Hallucis Longus, which lies deep to the Achilles tendon. What I'm going to do to palpate these is, I know that my FDL is a little bit more medial, right? Just medial to my fibula here, kind of on the lateral border of my tibia, but pretty deep. So I want to palpate through my gastroc and soleus. And then I'm going to have Melissa wiggle her toes. Right? No need for me to do guesswork here, guys. If she wiggles her toes, what I want to be able to feel is eventually under my fingers is something that feels like this. Right? If she just wiggles all of her toes, I should feel some fascicles jumping around underneath my fingers, and I need to keep palpating until I feel that. You know, it's better to take a couple extra seconds than to just be wrong. Alright, so I feel it right there. Now what I'm going to do is do my perpendicular palpations to look for tighter fascicles. And then I'm going to, once I find a tight fascicle, I'm going to start looking for that nodule, that knot that I think is contributing to the tightness in that fascicle. And right about here, I find a nice little knot in Melissa's Flexor Digitorum Longus. Now, from here I could just press deep. I could use my dummy thumb to create a nice thick palpatory spot, and then push her into a little dorsiflexion, making sure that I'm including her toes this time, because I got to push her toes into extension to also lengthen those long toe flexors, and then use my other hand to supply the pressure. So this thumb goes between my thenar eminences, right? After I find that spot, nice broad palpation. And I go right to the point of increased tissue density, right where that tissue starts to give back a little bit. and I hold. This is going to be a tender one though if I'm sitting here and pressing through a lengthened gastroc and soleus. I'm going to show you guys a trick here in a second that'll make this technique a little easier. Now once I've done that, I can go through, do the same thing with the FHL. Wiggle your toes for me. FHL is actually a little easier to find because rather than palpating through the thick gastroc and the thick soleus, you're really palpating through the very ends of these muscles. You know, the gastroc actually is probably has no fibers left down at this low. The soleus is pretty thin here. I'm going to do my perpendicular palpation here, strumming those fascicles. Once I find a tight fascicle, I can then look for a nodule. I found that one pretty quick. All right, once again, I'm going to use my nice broad whole thumb pad to push down on that trigger point. I'm going to put some length in that tissue to once again put some tension in that muscle, right? Or rather, only goes to here, but put some tension in that muscle and stabilize that trigger point so it doesn't keep flopping around. I don't want to play that fingertip on a marble game. All right. And then press down. Again, I'm pushing through some muscle, so this is going to be pretty tender. So here I want to show you guys a couple tricks so that you're not pushing through so much muscle. You do have to know who you're doing this on though. The first technique I'm going to show you, the individual needs to be a pretty stable, well-balanced individual. And the second technique, you definitely have to be aware of body position. So the first thing I'm going to have Melissa do is get into a kneeling position. Now if she gets into a kneeling position, she flexes her knee. I'm going to have her use this foam roll to get stable. I'm going to have her put this leg out in front of her. All right, so she's the knee that we're gonna, or the side that we're gonna work on, that's the knee that's down. She has this leg in front of her to take on most of the weight. She can lean over this leg even a little bit. You want to make sure she's nice and stable so that she doesn't need knee flexion and extension to keep her balance. And then what I've basically done, actually move this leg back a little bit. What I've done is I've put her gastroc on slack. So now rather than trying to push through all this stretched out tissue, and I've been telling you guys for a few videos now with these manual release techniques, we put tension into tissue to actually stabilize trigger points. Like it increases tension. So to put some slack back, now I can press straight down into this trigger point. Like there's, and you can see Melissa's face, there's like no resistance until I hit her Flexor Digitorum Longus. And now I can use the same technique. All right, same thing with her FHL. Like even though there's not as much muscle down here, like it's still so much less tension in this system that pushing down into her FHL is so much easier. And once again, I can hold for 30 seconds. Until I get a release, going right up to that tissue barrier. I should start to feel it melt underneath my fingertips. If I'm in constant communication with my client, hey Melissa, you starting to feel that relax a little bit? Doesn't feel as bad as it did when I first pressed in? Good. All right, so the last position that works well, guys, but you need to have a little bit of awareness and rapport with your client, is this position, which kind of looks like our hip flexor stretch, does take some balance. And you notice I have Melissa up on a treatment table, which becomes problematic if we're dealing with somebody who's not very well balanced. The last thing I would want is Melissa to fall over this way as I'm doing all these techniques. Melissa could go down into quadruped. Right, so go ahead and go into quadruped. So quadruped does the exact same thing for me. It's a very, very stable position. But I just want you guys to watch. Obviously, Melissa and I are close, we're friends, we've been doing this a long time. If I push here and then put my dummy thumb here, and I'm not careful where I'm looking, my face is going to be very close to her backside, which is not going to make either you or your client very comfortable. You can sit down. So although quadruped position is probably the best position to do that technique in, guys, just make sure that if you're going to do that, you have enough rapport with your client, with your patient, to kind of explain to them the position that you guys are going to end up in, and then make sure as you're pushing down, maybe you've practiced this technique enough that you don't have to look at your hands so much. I would definitely move, rather than being center, I would move off to the side of the table a little bit, and then only lean so that this shoulder is over your arm for your pressure, rather than being center on. It's just a little uncomfortable, and I don't want anybody getting in trouble for, you know, a stupid reason of just lack of body awareness. So next we're going to do our close-up review. So this is your close-up recap, guys. You can see that I have the FDL and FHL common trigger points mapped out for you. The FDL, the body of this muscle, where it's innervated by its nerve and where we think these acute points of dysfunction happen, is generally right between your medial and lateral gastrocnemius heads, of course deep to your gastroc and soleus. So when I look for this trigger point, I'm not even going to mess around. I'm not going to try to hit it right on the money. I'm going to have my patient or client go ahead and wiggle their toes. Good. You can even have them like curl your toes against your thigh if you're in this once again, this position with their feet hanging off, so that you can control the amount of dorsiflexion and plantarflexion. Keep going. And of course I feel right there. Once I have that spot, I want to make sure I push Melissa into dorsiflexion and toe extension. So you don't want your knee up here, right, where you're pushing her into toe flexion or dorsiflexion, but her toes can flex around your knee. You want to make sure that you almost got the toes pressed into extension first, because these are long toe flexors, and then dorsiflexion as you press down. That'll help stabilize where that trigger point is, so you don't get that flopping back and forth. Then you can use dummy thumb and apply enough pressure to get all the way through gastroc and soleus until you start feeling the tissue melt away, the discomfort start to reduce. Now, of course, this is FHL. FHL is a little easier to find as there's not so much tissue to get through here. We'll use our palpations across the fascicles first. Look for the densest fascicles. Move proximally and distally to try to find the nodule in those fascicles. Once we found it, we can kind of push with a nice broad thumb. No need to press straight down and play the marble fingertip on top of a marble game. All right, put some tension in that system to help you stabilize the trigger point. Push up this way. I do find a little distal to proximal pressure along with posterior to anterior pressure helps. And I can do the same thing, pushing right up to that point where I see a big increase in tissue density. So we know that we have this like kind of linear relationship where tissue density slowly increases as we press into tissue, and then all of a sudden as we hit that trigger point, get deeper, all of a sudden like tissue density like ramps up real fast. We want to be just in that trough. And of course I showed you guys the trick of getting some of this tissue, getting the calf tissue out of the way, well, the gastroc and soleus anyway, and then adding a little bit of laxity back to the Achilles tendon by having your patient or client go into either a kneeling position or a quadruped position. Just be real careful on where you end up versus where they end up, and you're having that conversation about why you're doing what you're doing. You can see now, like, just as I poke her gastroc here, there's like no resistance, and it's because we put some tension back into her gastroc. I can push straight down, and almost like the first resistance I feel is her Flexor Digitorum Longus. This is of course just thumb over thumb compression, which I wouldn't necessarily use on these techniques. We'd go back this way and then go hand over thumb, and that helps save our thumbs a little bit. Once again, I could use 30 seconds or until I feel the tissue melt away, or I could use those multiple repetitions of 5-second holds. Let's say she was so tender that I couldn't even get to that increase in tissue density. I could slowly work into it with 5-second holds until the tissue desensitized enough for me to actually get some sort of mechanical release. So there you guys have it, FHL and FDL, static manual release technique. Great technique to add to your repertoire, a very overlooked set of muscles. Muscles that do have a propensity to become synergistically dominant in lower extremity dysfunction. Ensure that you are doing assessment first and you're pretty sure that these muscles are involved, because that back of that leg is a sensitive area to be pressing on. And remember, you're going to have to press through quite a bit of tissue, through your gastroc, through your soleus. Be careful as you experiment with the other positions we showed you, the kneeling and the quadruped position. Make sure that you explain to your client what you're doing and where your body positions are going to end up, so there are no misunderstandings. And of course, grab some friends and get to practicing before you pull this out with patients and clients. I think just having it done on you, as well as doing it to other people, and then being able to compare with you and your colleagues, is such a wonderful learning experience. As a profession, we don't do enough to work together in groups. I really think that every clinic, every PT should have a group that they go to where we could do some maybe practice together, because manual techniques done on manual therapists with interaction, that's some powerful learning. I look forward to hearing about your outcomes. I look forward to hearing about how this changed, some of the outcomes you saw when you added it into your repertoire. I'll talk with you soon.